Overall, the key thing about ICH is in comparison with ischemic stroke, which is its close counterpart, the mortality is exponentially higher here because 6% of patients die even before they reach the hospital. More than 30% of patients die within the first 30 days. And especially if they show up with really low GCS or a very large hemorrhage, then those patients, the mortality is almost as high as 90%. So putting that into perspective, I think ICH by far becomes the most devastating type of stroke that we tend to treat in daily practice. And ICH can occur in different parts of the brain, but more or less it is always within the parenchyma of the brain. This is something that we call a putaminal hemorrhage. It's also a deep hemorrhage. The main classification of hemorrhages would be superficial, deep, and infratentorial, or a brainstem hemorrhage. So this would be a classic deep hemorrhage. You can also get another type of deep hemorrhage, which is in the thalamus. So it's thalamic hemorrhage. This would be the classic lobar hemorrhhage, which includes any of the cortical lobes, and it's very superficial usually. And this is again an example of a deep hemorrhage, which is in the caudate nucleus. And this would be a pontine hemorrhage, which is infratentorial. This is also involving the brainstem and the cerebellum. So what do we know about the different locations? By and large, I think the most common location of an ICH is usually in the deep areas. That's like the caudate, putamen, thalamus. And that accounts for about almost 65 to 70% of all the ICHs that we see. What comes next is the lobar hemorrhages, which usually account for about 20 to 30%, and the rest are the cerebellum and the brainstem hemorrhages, which are usually about 10% or so. The most common cause of ICH is actually a traumatic ICH, but when we talk about ICH in general, we refer to the spontaneous ICH, which is the non-traumatic type, and that is what we'll be referring to for the rest of this talk. So spontaneous ICH can be either primary or secondary. Primary is when it usually is because of hypertension or amyloid angiopathy, which are known to cause ICHs. Secondary, when it can be because of some sort of a tumor, a vascular malformation, or it could be from a clot in one of the big cerebral venous sinuses, or because of ischemic stroke. This is a really nice depiction of what you can expect. So these would be the deep hemorrhages. Most often, deep hemorrhages are because of poorly controlled long-standing hypertension. And also in the brainstem, it would be usually hypertension that would be the number one cause. But when you look at the superficial causes, about half the times it's hypertension, and the remaining half of the times it could be because of different things like amyloid angiopathy, which we'll touch upon in just a bit. To give you a sense, so these are two different types of primary ICHs that we see. And when you get an MRI on the susceptibility weighted or the GRE sequences, you look specifically for microhemorrhages. So when you have microhemorrhages, there is hemosiderin that is deposited, and that shows up as these dark spots on the MRI. And that generally means that there's been old hemorrhages, which are usually asymptomatic. And if these old hemorrhages are more or less clustered in the deep areas of the brain, that gives you an indication that it's likely to be hypertensive etiology. On the other hand, if these microhemorrhages are superficial and located mostly in the cortex, then that's more indicative of amyloid angiopathy. So amyloid being similar kind of amyloid that you see with Alzheimer's disease gets deposited in the blood vessels here instead of the brain parenchyma. And so the blood vessels become very fragile, leaky, and that can cause big hemorrhages. So the most common causes of ICH, if you were to break them apart based on age distributions. So in the younger patients, less than 40 years of age, it's most likely some sort of a vascular malformation, vasculitis, drug use. If you're looking at 40 to 80, hypertension pretty much becomes the number one factor. Over the age of 80, you can again attribute cerebral amyloid angiopathy as the most common cause, but then hypertension comes a close second. Obviously, in any of these age groups, you can have other secondary causes, and you should always actively look for these causes. To give you an example of some of the secondary causes of ICH, so this was a patient that we had in our ICU a few years ago who presented with a right frontal intracerebral hemorrhage. And you can see on the CAT scan here. And as it turns out, when the patient ended up getting PET imaging, this is a CT PET, there was actually a tumor. So this is a tumor-related bleed. And the patient ended up going to the operating room and having the tumor resected. You can also have an AV malformation where there is an abnormal connection between the arterioles and the venules. So there's no capillaries here, and this becomes a nidus, which can bleed and also cause hemorrhages. Usually AVN bleeds are again seen in younger patients. Some of the other causes would include atypical causes like sinus venous thrombosis. So here you can see that the sigmoid sinus on the left side is completely occluded, completely thrombosed, and there is an area of venous hemorrhage here, because what happens here is there is backflow of blood flow. As a result, there is increased pressure here, and that causes slow oozing, and so it's a venous bleed, not quite the same as an arterial bleed. This is an area of ischemic stroke, and this patient received TPA and ended up having a hemorrhagic transformation of an ischemic stroke. You can say that because the area of hypodensity is much larger, and there's a smaller area of hyperdensity, which is the blood. So whenever you see a patient with an ICH, you're always thinking of any potential underlying vascular causes. And so to help make this easy and objective, there is something called as a secondary ICH score, or the SITCH score, and it essentially takes into account what your probability is based on the CT findings, the age of the patient, the sex of the patient, and whether the patient has any hypertension history or any impaired coagulation parameters. So with that, you can assign a score, and it's usually a clear, a very easy score to use. There's like apps for this. And what the score tells you is, as the score approaches 6, which is the highest, you'll see that the predictive accuracy for diagnosing a secondary or an underlying vascular abnormality is close to 100%. But if the score is anywhere between 5 and 6, usually it's very accurate. And lower scores obviously will mean that you don't really need to aggressively pursue further workup for underlying causes. Now, one of the main things that comes up every time you have this patient, from the time the patient is wheeled in through the ICU doors, is everybody wants to know what the prognosis of this patient is, right from the family members to members on the team. And to help with that, we have 2 scores that we use. This is pretty much the most commonly used score that we use in clinical practice, which is called the ICH score. And it takes into account 5 different or 6 different aspects. So GCS, with lower GCS being awarded more points, and age over 80 being awarded some points. If the location is infratentorial, that's pons, brainstem, cerebellum, then that's considered bad. Larger the bleed, more the points. And if there is presence of blood within the ventricles, that also gets some points. So the score ranges from 0 to 6. And as the score approaches 4, you can see that the mortality is like almost like over 95%. So anywhere between 4 and 6, it's definitely not a good sign. And this is usually representative of 30-day mortality. It's not mortality right away. And this could be mortality, not just from the bleed, but could be from sepsis, from PEs, DVTs, you name it. There's another score, which is called the FUNC score, which uses more or less the same sort of parameters, with the exception of cognitive impairment. So here, the claim is that if somebody were to have impaired cognition at the time of their bleed, then they're more likely to have poor outcomes. But otherwise, the score pretty much gives you a sense of functional independence as opposed to mortality that you get with the other score. So if you want to paint a positive picture, then you tend to use the FUNC score. But if you want to really inform the family about goals of care, then ICH score would be more useful. So now you have a patient who comes in with a bleed. So the first 72 hours, or maybe even 96 hours, would be crucial. And in the ICU, pretty much 5 of these things stand out, and that's what you're thinking of at all times. The first one being hematoma expansion or enlargement. Then you worry about the bleed extending into the ventricles causing hydrocephalus, seizures, obviously. And then as the bleed expands, there's also going to be swelling or perihematomal edema, which can cause a mass effect and downstream complications. And finally, all of this can lead to ICP elevations and herniation. So the rest of the talk is going to pretty much focus on these 5 aspects. The 5th aspect, I'll leave it for a next talk, but we'll focus on the others in more detail. So what exactly is hematoma expansion? So hematoma expansion is, as the name indicates, the bleed enlarging. Usually we get scans in the first 4 to 6 hours. We repeat scans in the first 4 to 6 hours, mainly to see if the bleed is stable or is worsening. And this is an example of how the bleed can expand. It's like just a trace expansion here, but you can also see that there's no blood or very little blood within the ventricles, but here there's more blood starting to accumulate. Why is hematoma expansion important? Because we know that hematoma expansion is pretty much the most independent predictor of poor outcome. And every cc that the bleed expands, it worsens or increases the likelihood of poor outcome by 7%. And in this study, they looked at how the hematoma worsens over time. And as you can see, in the first 3 hours is when the hematoma growth is the fastest. After that, the rate of expansion of the hematoma slows down, but it's still growing at this point till the end of the 24-hour mark. But this is when the first 6 hours is when it is significant, and the first 3 hours is when it is absolutely the highest. And this is, we're talking about from the time of symptom onset. And factors that really affect hematoma expansion are time from symptom onset. So if somebody presents to you within an hour of having the bleed, then you can expect the bleed to get worse because you know that that is the usual timeline. But if somebody presents to you 8 hours out, 12 hours out, then the chances of hematoma expansion are a lot less. And then obviously, if it's a bigger bleed, that's more likely to expand. And any sort of antithrombotic therapy, be it antiplatelet or anticoagulation, that should also warrant you, especially if anticoagulation is on board. So how do you pick hematoma expansion? So one of the key things that we do is also get a CT angiogram. Now, to give you a comparison here, this is a non-contrast CT of the head, which shows the bleed. And on the right side here, you have the CTA. Here, the bleed is sort of attenuated because of the contrast. But what you can see here is a spot lighting up within the hematoma. So this is the spot sign, which indicates active extravasation. And if you repeat the scan, you can see that the bleed is now getting worse. Same thing here. This was a patient that we had who essentially had a small hemorrhage. CTA showed 2 spot signs. And then we repeated here, actually the spot signs on the repeat CTA are also bigger. And obviously the bleed got bigger. There's more IVH or intraventricular hemorrhage. There's more hydrocephalus. So that is the utility of the spot sign. If you see it, then there's almost an 80% chance that the hematoma is going to expand. And what are the things on the spot sign? The more the number of spot signs, the bigger or brighter, then all these are poor signs that the bleed is going to expand. And it's almost 90% sensitive and specific to tell you that the bleed is going to expand. So if you see that, then you need to become more aggressive. So what can you do to prevent the hematoma from expanding or limit the expansion? 2 things come to mind. One is intensive or aggressive blood pressure control, and the other is reversal of coagulopathy. So the 3 men in this picture, I don't think need any introduction. This is from the Yalta conference in 1945 after World War II was over. Some of you may want to replace these with some current politicians, but I'll leave it up to you. But to give you a sense, hypertension spares nobody. And Winston Churchill at this time of this conference had a blood pressure of 160/90. He went on to have multiple strokes over the next 5-6 years. FDR was actually looking very pale and very sick that particular day. And when examined by Churchill's personal physician, he was found to have a blood pressure of 260/150. And 3 months later went on to have a pretty big ICH. And Stalin was known to have his blood pressures in the 200s. And a few years later, I think, ended up having a fatal ICH. So the theme here seems to be hypertension and stroke. As a result of So from what we've learned from history is probably going after blood pressure is one way of treating or limiting hematoma expansion. And that led to two big trials. One was the Interact 2. This was a trial that was done in Australia and China. And what they found was that if you have two different arms, one, they had an intensive blood pressure arm where patients were treated to less than 140 systolic, and the liberal arm was systolic blood pressure less than 180 millimeters of mercury. Unfortunately, there was no difference in their main outcome, which was death or major disability, but there was a strong trend towards good outcome favoring intensive blood pressure management. So less than 140 sort of became the norm after this trial came out. A few years later, the NIH-funded American Attack 2 trial came out, and here they had about 1,000 patients, and they had the same intervention, intensive versus liberal blood pressure control. Unfortunately, they found absolutely no signal whatsoever. What they did find was if you control blood pressure very aggressively, you can have more renal complications. But one thing to keep in mind is when this trial came out, the prior trial, ATAC 2 trial, had already interfered with some of the management here, because even the patients who were supposed to be liberally controlled in terms of blood pressure had very strict blood pressure targets, and they were closer to the 140 range as compared to the previous trial where they were closer to the 180 range. So I think that may have also blunted any difference. With that said, the American Heart Association guidelines, which are due to be revised soon because these guidelines are almost 7 years old, what they tell us is if somebody presents to you with an ICH and has a blood pressure at the time of presentation between 150 and 220, then it is totally reasonable to bring it down to 140 or less. But for somebody who has a blood pressure greater than 220, I think that is when you need to be a little more cautious. Perhaps bringing it down to less than 160 or so is better in terms of avoiding any renal complications. The most important thing is not just controlling the blood pressure, but you want to control fluctuations in blood pressures. So it is the blood pressure variability that is actually worse for patients with ICH in the first 24 hours rather than just hitting one number, because we know that even Cardine is not very effective in just keeping the blood pressure tightly controlled. So what this study showed is that this was a study where they pooled data from the two trials that I just talked about, and they found that if you have a lot of blood pressure variability, more the variability, worse the outcome. So here the odds of outcome, good outcome, are decreased by almost 30%. And more the variability also increases your odds of death. And it also increases your odds of hematoma expansion. So targeting blood pressure variability should be the key. And you also want to be as quickly, it's almost like time is brain sort of an approach here. You want to control blood pressure as soon as the patient hits the door, because ultra early blood pressure treatment and reduction will also help with not just hematoma growth, but will promote functional independence and good outcome. So that should be the key. So we talked about blood pressure targets. We know that blood pressure is important. What about coagulopathy? So, one of the things that can cause coagulopathy is being on an antiplatelet medication, and platelet transfusions pretty much are done everywhere across the board. But is that the way to go? And this was a randomized clinical trial where about 100 patients with ICH were randomized to either get platelet transfusions or not, and just be randomized to standard medical therapy. These were patients who were all on an antiplatelet medication previously at the time of ICH. And surprisingly, what this study showed is that if you were to actually give patients platelet transfusions, then that worsens their odds of improvement. So MRS of 4 to 6, MRS is a score, it's called modified Rankin score that we use, 0 being no disability and 6 being death. So 4 to 6 would mean severe disability or death. And as you can see here, the platelet transfusions increase the odds of poor outcome by 2-fold. So most institutions that I know of, we have started tending away from giving platelet transfusions until there is some surgical indication, like putting in an EVD or taking the patient to the operating room. Otherwise, we just conservatively manage patients nowadays. And what about hematoma expansion that could result from coagulopathy from other causes. So we know for a fact that warfarin can definitely cause coagulopathy, thins down your blood, INRs are elevated. And one thing that you can use is prothrombin complex concentrates, or PCCs. And in this clinical trial, they compared PCCs to fresh frozen plasma, and clearly the time to INR reduction or INR getting into the normal range was significantly faster, or the odds ratio is like 30 times faster for prothrombin complex concentrates compared to FFP. So we typically tend to use PCCs. The advantages of PCCs are it obviously has a lot less volume. As I said, it decreases your INR to the normal range in like literally no time and can be given very fast. And this is the dose of Kcentra that we normally use. Usually it ranges anywhere between 25 to 35. And about 6 hours later, if the INR is still out of range, you can repeat a dose, which we do sometimes, but fairly infrequently. In terms of what the American Heart Association recommends is that if you have an INR elevation, then definitely also consider vitamin K. And they have also started recommending PCCs as the standard reversal agent after somebody has warfarin associated bleed. Now, we also have a lot of newer agents in the market now, the novel or the direct acting anticoagulation agents. So NOACs or DOACs, you have different ones. More or less, PCCs tend to be effective in all these cases. But for dabigatran, we have a randomized clinical trial which clearly showed that the specific binding antibody, idrazusumab, is actually very effective. And so for dabigatran, that's when we use this specific medication. The trade name for dabigatran is Pradaxa, and this medication is called Praxibind, which is definitely available at NYP. As for these three medications, we tend to use PCCs. There is an approval for andexanet, which is a binding agent, but PCCs in general cost about $5,000 compared to Andexa, which costs like 30 grand. So clearly, in terms of cost and no clear additional benefit, we tend to favor PCCs. Now, there are other medications that you'll also see which can lead to patients having ICHs. One is TPA. And if you were to encounter a TPA bleed, then obviously first stop the TPA infusion. Amicar is something that you can, amino caproic acid is something that you can definitely consider. And if the cryoprecipitate level, cryoprecipitate can be given if the fibrinogen levels are usually lower than 150. Heparin frequently comes up. We use heparin drip for a whole lot of indications. There are different protocols and policies. This is the AHA policy where it says that if the heparin drip was stopped less than an hour, then you need to reverse with protamine, and the dose of protamine is a milligram per 100 units. If it's 1 to 2.5, then it's half the dose. And if more than 2.5 hours, it's up to you. You can choose not to use any protamine or quarter of the dose. Same thing with Lovenox. Protamine still becomes the medication of choice. So with that, we'll move forward to the next section, which is intraventricular hemorrhage and extension, and what it does in terms of hydrocephalus. So this is an example of how a normal ventricle should look like. And when blood seeps into the ventricle, there is ballooning of the ventricle, obstruction to the flow of CSF. And so now you have hydrocephalus and you have intraventricular hemorrhage. How do patients manifest clinically? It usually shows up with, the patients show up with headache, vomiting, progressive lethargy, drowsiness to the point that they get comatose. They start snoring. That's a classic sign that we see when altered mental status because of a neurological condition starts. And so what we do is we place an EVD, or an external ventricular drain. And this is a drain that goes all the way in. It is tunneled into the brain. It's a bedside procedure, as most of you know. And it helps do with two things. One, it acts as an alternative conduit for the passage of CSF, which is collected into this bag when the drain is open. And every hour or so, we clamp the drain to get the manometry reading of what the intracranial pressures are. So it not only helps with drainage, it also gives you a sense of what the levels are. So clearly, that is the way to go to help with drainage. Now, while you have access to somebody's ventricles, you also have the option of giving TPA. Now, you may think that giving TPA into an active hemorrhage is counterintuitive, but as it turns out, TPA can break the clot open and also has some anti-inflammatory properties. As a result, we do this in clinical practice, not with the intention of improving outcomes. Unfortunately, there was a big clinical trial called CLEAR 3, which showed that it doesn't really improve patient outcomes, functional disability. But clearly, we do it when patients have high ICP crises, and sometimes to improve flow and decrease their chances of requiring permanent PP shunts later on. To give you an example, this is a patient that we had who came in with a large IVH, and this is the EVD that's sitting there. We gave TPA, I believe, about 5 or 6 doses, and you can see it's pretty much all cleared out. So radiologically, there's definite clearance of the ventricle. This is another example of a patient with 4th ventricular blood here, and this is blood in the 3rd ventricles. So this generally means that there's absolutely no passage for the CSF to flow, and you can see after TPA was given, the 4th and the 3rd ventricles are almost pretty much completely open. Now, it's a shame that it didn't really improve outcomes, but otherwise, it still looks like a fairly promising therapy. And this was a trial I was talking about, where they looked at functional outcomes in patients who were given TPA and those who did not get TPA. Unfortunately, there was no difference. But what they did find was if somebody came in with a large IVH, there's a lot of blood in the ventricles, more than 20 cc's, then in those patients, TPA tended to be more effective. So perhaps we were targeting the wrong set of patients to begin with, and we need to be a little more careful in selecting patients. And what about seizures? So seizures obviously are fairly common after ICH. And the way to think about treating seizures or considering prophylactic medications is we do not normally consider anti-seizure medications in patients with ICH. The only time is when somebody has a clinical seizure, or if there's a high probability that the mental status is out of proportion or the exam is out of proportion to what you're seeing on the scan. That's when we do continuous EEG monitoring. And if the EEG shows seizures, then we start seizure medications. So either electrographic seizures or clinical seizures would be indications, not just an index of suspicion. That's not the way to go per the American Heart Association guidelines. And what about perihematomal edema? So perihematomal edema, as the name suggests, is the swelling around the bleed. So this is a CAT scan showing the bleed, and this is the swelling around the bleed. The same thing here, this is the bleed, and this is an MRI showing the significant vasogenic edema. To give you a sense, the CAT scans can pretty much undercall or underestimate the bleed. So this is one of our studies, research studies, where we use 3D softwares to quantify the degree of edema. And as you can see on the scan here, it looks pretty much unremarkable. But when you map it out and you subtract the hematoma volume, this is all the edema. It actually looks pretty sizable, right? And so several studies have shown that perihematomal edema can worsen outcomes long-term, and so it should be treated as early as possible. And to give you a sense of how bad edema can get, usually the rate of rapid growth is in the first 2 days. And after the first 2 days, it still tends to grow, but not quite as much. And by about 10 days, 10 to 14 days or so, it starts plateauing off. It doesn't go away, but for months on end, it just plateaus off. So that is a natural course of edema. And if you were to plot it, as time progresses, the rate of growth of edema slowly comes down. So why is that important? Because people are now starting to target perihematomal edema as the main target to improve outcomes after ICH. And there are some surgical options that we can do for ICH. So the conventional thing is doing a craniotomy, taking the cortex out, or doing a cortical dissection and going after the bleed and evacuating the bleed. This was the usual surgery that was done. Sometimes you can do a life-saving surgery where you just do a decompressive hemicranie, take the skull flap out and let the brain swell outward, but in this case, you do not touch the hematoma. Is surgery beneficial or effective? So to answer this question, there was this big randomized clinical trial that was done called the STITCH trial a few years ago, almost 20 years ago. And unfortunately, the trial did not show any benefit of surgical intervention. And the surgery we're talking about here is, going back one slide, is the old approach of a craniotomy and then doing a corticectomy and taking the blood out. So unfortunately, there was absolutely no benefit. But what they found in this trial was if the bleed was within 1 centimeter of the cortical surface, then those patients tended to benefit from surgical evacuation. So that led to the second trial, which is the STITCH 2 trial, where they only went after patients who had a superficial bleed that's within 1 centimeter from the cortical surface. But unfortunately, even here, there was no difference between the two outcomes. So surgery, as promising as it was back then, did not really pan out. And so people were still not ready to give up. And what they did was they looked at a combination of all the trials, surgical trials, and they pooled the patients. And they found that if you intervene when somebody's GCS is between 10 and 13, then those patients tend to benefit. But if the GCS is very low or very favorable, 14 or 15, then those patients don't really tend to benefit that much from surgery. So that gave us some important information. So that has led to some newer techniques that we use in clinical practice. This is the latest in town, which is called minimally invasive surgery. There are 3 different types of surgeries that are offered. This is the stereotactic aspiration with thrombolysis. So you just aspirate the clot out through this syringe-like thing. This is called minimally invasive surgery with direct visualization. So what you do is this hollow tube, which is about the same diameter as maybe a penny, goes into the bleed cavity along the longitudinal axis. And then this is what the surgeon sees. And then this is a cortical vein sitting on top of the brain surface. You go straight into the hematoma and aspirate the hematoma out under direct visualization. There is no microscope, it's straight up. Here, this is an endoscopic approach where this is done very similar to, it looks very similar to a laparoscopic appendectomy, for instance, where this endoscope is inserted into the patient's head. And then this is what the surgeon would be seeing on the camera. And this is the inside of the hematoma cavity after the blood is all evacuated. And you can see this is the bleeding focus here. So these are the 3 things that are done. At Cornell, we tend to use the minimally invasive surgery with direct visualization approach. We use this device called Neuro. It can be used for brain tumors also, but that's what is used here for hematoma evacuation. But not all patients get hematoma evacuations, and minimally invasive surgery is currently being done in the setting of different clinical trials, so we're hoping to get some answers. To give you a sense, this is a patient who came in with a large right-sided basal ganglia hemorrhage, underwent minimally invasive surgery, and you can see there's like very minimal tissue damage and most of the blood is all out. And this is another example of a patient who came in with a fairly large bleed and most of the blood is out, or all of the blood is out. So this was a clinical trial called MISTY 3 that was published a few years ago, where they investigated the minimally invasive approach versus standard therapy. And unfortunately, there was no difference between the 2 arms. But this is one of the earlier trials, and we have learned a lot from these trials. So there are several other ones that are currently looking at more modern minimally invasive techniques, particularly with the NICO device and with the endoscopic approaches. Those are being investigated now. And finally, ICP elevations and herniations. So the most important thing to remember is you can have a herniation event, which is what we call a brain code, and you should have the same sort of urgency that you would have with a cardiac code or a code blue. Patients will end up showing up with like blown pupils, anisocoria, altered mental status. There's extensor or flexure posturing. And if an ICP monitor is in place already, then you will see that the ICPs are obviously high. There can be non-neurologic or systemic manifestations of a herniation event, which include hypertension, bradycardia, and irregular breathing, which is what we call Cushing's response. So that's something to also keep in mind. So in the ICU, nausea, vomiting, bradycardia are taken very seriously for the same reasons. Now, I'm not going to go into much detail because I believe there is a dedicated lecture on ICP management sometime in the near future, but so I'm going to skip this concept. So just to give you a recap before I conclude of how you manage patients with ICH. So this is our protocol that we use in the ICU. So every time a patient is wheeled in through the emergency room, neurosurgery and neurology get consulted. And the first thing that you do is ABCs, like you do for any emergency. And then you get a CAT scan, find out that the patient has an ICH, target blood pressure. We target less than 140. If the patient comes in with extremely high blood pressure, sometimes then we do less than 160. You can do labetalol, you can do hydralazine. Preferable to use Cardine early on and just get continuous blood pressure or decreased blood pressure variability in the early setting or acute setting. Look for any coagulopathy signs. If the patient's on warfarin, any of the other NOACs, if there's TPA or heparin on board, then make sure you give the appropriate reversal agent, vitamin K, if required. And sometimes if patients have thrombocytopenia, or if they have platelets, antiplatelet medications on board, and they have documented alcoholic liver disease or renal disease, we also do give TDAVP sometimes. Surgical intervention is considered on a case-by-case basis, mostly because there is no clear evidence that it's of benefit, but it is done in the setting where you have a lot of mass effect, where you have a lot of ICP issues as a life-saving approach. So on a case-by-case basis, some patients undergo decompressive hemicrania, and some patients get a minimally invasive surgery done. And once all those things are done, you want to get some sort of repeat imaging in about 4 to 6 hours to see if the bleed is still expanding. You also, at the time of the second scan, we tend to add on a CT angiogram sometimes to see if there is any CT spot sign, which will tell you that the bleed is going to expand. Usually this is paired with the initial CT head to begin with, so we have that information up front. Once the acute bleeding situation has resolved, at some point in the first week or so, you tend to get an MRI, and that is to see if there is any amyloid angiopathy or if it's just straight up hypertension. If you're worried about an underlying cause, then we expedite the MRI, obviously. Consider the MRV if it's an atypical bleed and you're thinking of venous thrombosis. And if the secondary ICH score is fairly high, then the patient buys a digital subtraction angiography, which is essentially a conventional angiogram to see if there's any lesion. And if there's a lesion, it usually is treated at that time. Always ventriculostomy is something that you would consider also in EVD, and this is done early on. TPA, again, on a case-by-case basis. If the EVD is sitting in a lot of blood, tends to clot off a lot, or if there's a lot of ICP issues, then we give TPA into the ventricles. DVT prophylaxis usually comes up. We demonstrate bleed stability at 24 hours, and we usually start DVT prophylaxis with sub-Q heparin at 24 hours, once we are convinced that the bleed is stable. And then seizure prophylaxis, we usually follow the American Heart Association guidelines. We only do AEDs if the patient is having clinical seizures, or if on video EEG or continuous EEG, there is evidence of electrographic seizures. And those would, or if the patient has a prior history of epilepsy, then obviously you want to continue those medications. There are other complicated issues that come up, which tend to revolve around when to resume antiplatelet, anticoagulation medication. There is clearly no data out there, it's only observational studies. So this requires a lot of high-level discussion between different teams, and we still tend to favor starting antiplatelet therapy in most cases if required, but anticoagulation becomes a lot more challenging. There are several clinical trials looking at these things, so hopefully we'll have these answers in the near future. With that, I think pretty much I'm done with my talk. I have about 10-15 minutes left, so as I promised, I wouldn't eat into the whole hour. Do you guys have any